Okay, so good afternoon, everyone. It's my pleasure to be here. We're going to talk about this very important topic, polypharmacy. And my goal is not just to have you learn about this for the clinical aspect of it, but I want you to be aware of all these tidbit information, facts for yourselves, for your family members, and for the people that you care for. Polypharmacy is a very, very important topic. My name is Nancy Rodriguez-Weller, and I am a retired professor from the University of Maryland Eastern Shore School of Pharmacy. And this is my passion, educating, talking about topics such as this. So, polypharmacy, what is it? This example is an example of polypharmacy. One of my patients takes this many medications in the morning, at 9 o'clock in the morning. Okay, if you look at it, it's about 40 drugs. Now, she takes that once a day, but then she takes another 2 doses at lunchtime and then before bedtime. Polypharmacy is a huge problem in older adults. So my wish is that we could put it all in one pill, but that would not happen in real life. So this is a topic that we really do need to pay attention to. So my goal today is to identify what polypharmacy is. Specifically, we're going to talk about the consequences that occur because of polypharmacy. I'm going to address and have you become familiar with some of the tools that clinicians use. And then I'm going to talk about a plan that you can use for either, again, yourselves or in your practice or in your daily lives. So polypharmacy is very, very common in older adults. 1/3 of older adults are prescribed at least 5 medications or more. And sometimes they're appropriate and sometimes they're not. But it's expensive. Polypharmacy is expensive and it's really hard to manage. Think about what happens when you are prescribed medications. You also have to think about that the more medications that someone is prescribed, the higher the increase for adverse drug effects and drug-drug interactions. And I also want to add that it's not just increasing the burden on the patient, but it increases the burden on the family members as well. And in some cases can even lead to misuse. So, the National Institute of Aging definition says that it is the use of multiple drugs to treat diseases and other conditions in which patient is prescribed at least 5 medications. But I often see that happen with just 2 or 3 medications. And what I mean by that is that I can see where even if a patient's prescribed 2 or 3 medications, maybe 1 or 2 of them may be inappropriate, or maybe the 2 may have drug-drug interactions. This polypharmacy occurs in 20 to 30% of older adults. And it occurs because of multiple prescribers. Now, I see all of you had lunch. You're all happy, healthy, right? How many doctors do you go to as a healthy individual?
1.
1? Who would that be?
Primary care.
What's that?
Primary care.
Primary care. Okay, who else? Anybody else want to add to that? Yes. GYN. If you're a female, you're going to see a GYN even if you are healthy, right? Or you should. Okay, what's the other one?
Dentist.
Your dentist. That's already 3.
Your eye doctor.
Your eye doctor. 4.
Your gastro doctor after a certain age.
What's that?
The gastro doctor.
The GI doctor. Okay, we're going to get to that one. But for healthy individuals, you at least, at a minimal, should be seeing 4 physicians. Now, I can also add psychology, okay, because healthy individuals can see a psychologist. Okay, so that might be 5, and even 6, dermatology. Now, let's go into what happens after the age of 60. After the age of 60, I'm an older adult. And when I go out to play pickleball, I no longer hear conversations about my kids or the kids. We hear conversations about ailments. My knee hurts. I have a headache. I have stomach issues. I have anxiety, depression. So after the age of 60, things start to change. So you start to see more specialized physicians. Who would those be? Orthopedics? GI doctor?
Cardiac.
What's that? Cardiac? The cardiologist? Who else? Rheumatologist, endocrinologist, psychiatrist. Let me think. Hematologist. What was?
Pain management.
Pain management. Yes. So the list goes on and on. Okay, now think about this for a second. Do you think they all communicate with each other?
Should they or do they?
Do they? Do they? Should they is another topic, right? Yes. Do they communicate with each other? And the answer is no. And again, the more complicated the patient's condition is, the more complicated it is in the communication factor. Poor communication between the physicians themselves and the pharmacies and the healthcare system in general. Poor communication. Patients can also cause polypharmacy because they're looking for a cure. Patient may go to the physician and say, I am not feeling all that great and I would like a prescription. Okay, they're looking to take care of that problem at that moment. So what happens when polypharmacy occurs is more drug-drug interactions, an increase in adverse drug effects, compliance start to go downhill. The more medications a person takes, the more difficult it becomes to remember to take these medications. Of course, cost is an issue. Even though we have insurance plans, you still have to pay a copay, and it all adds up. And for me as a clinician or any other clinician, it becomes very complex to get rid of or taper the medical care of a patient, the more medications they're on. Okay, so moving forward, I'm going to show you some slides, and I'm going to go through them briefly. I don't want to go into them because of lack of time. But this current statistic right here is relating to polypharmacy, statistic provided by the CDC. And it reports that the number of prescriptions in 2014 increased from persons older than 65 from 2.5 to 10 prescriptions daily by the year 2022. So back in 2014, doctors weren't prescribing as much, but we're doing a lot more 2024. Another statistic I want to show you is a study that was conducted by Global Health Research, where it took 55,000 people over the age of 20. Now, this is general adult population, and this survey showed that prescriptions increased from people, again, from 1999, from 8.2% all the way to 17.1% by the year 2017. So overall, even throughout our all population, this is occurring. This slide indicates that women are often prescribed more often than men. Why is that? Why are women taking more medications? Yes.
They go to the doctor more.
They go to the physician more often. Is that true, Mr. Jim?
That is true.
That is true. Yeah, my husband refuses to go to the doctor. So, yes, women tend to have more follow-up visits. They tend to go to the physician for more things. Now, this is an interesting graph when we compare races. Polypharmacy is higher in non-Hispanic whites, followed by non-Hispanic blacks, followed by other races. This slide indicates that as one ages and becomes older, there's an increase in prescription use. Now notice the difference of polypharmacy between the age group of 20 to 39 and the age group of 65 and over. It's a big jump. And the more diseases found in an individual or specific disease that a person may have, there's an increase in the number of medications. If you'll notice here that polypharmacy tends to occur more often in people who have heart disease and diabetes, followed by hypertension, cancer, high cholesterol, and respiratory diseases. Okay, so this is a summary of that data. Again, it's provided by the CDC, and you can look into it if you'd like. But ultimately, look at what the cost of overprescribing is. Between the ages of 18 to 34, it's only $124 probably million or billion dollars. Whereas by 65 to 79, we have an increase of 811. Big increase in the cost of medications. Okay, so let me ask you this. Why does polypharmacy occur? Anyone?
Multiple conditions.
Multiple conditions, we just talked about that, yes. The fact that, as we age, we do have a lot of changes going on. So physicians typically will see patients that have conditions coming up. Now, physicians are responsible for polypharmacy in the older adult population if they lack education or competency in geriatrics. Keep in mind that even if a physician wants or can take care of his geriatric patient, the overload of the work that they have doesn't give them the opportunity to spend another 40 minutes with each patient. They're on a time clock to see the next patient. So they're not spending enough time with the patient, not by choice, but because of the logistics. Also, some physicians may not adhere, or they may adhere to multiple guidelines to prescribing. Another factor to why polypharmacy occurs are the system level factors. And by that I mean that the systems don't talk to each other. So think about what happens. I'm on the Eastern Shore, Tidal Health, and a patient is being transferred from Tidal Health to Johns Hopkins. They have different computer systems. And so they're not really interacting with each other the way they should. So miscommunication occurs. Communication is not that good between the prescribers, the transitions of care. And I have a personal story to share with you because my mother had a stroke a number of years ago, and she was in Philadelphia in the hospital, was seen by cardiologist who prescribes Xarelto. She was discharged, asked to go down to the pharmacy, the outpatient, have her prescription filled for Xarelto. And when she got home, she looked through her medication and thought to give me a call. Her question was, so, the label on the bottle says caution with bleeding. My other medication says the same thing. Should I be taking them together? What do you think happened? She was on 2 anticoagulants at the same time. She was prescribed Xarelto. She was never told to stop the Eliquis. That could have been serious. Now, not every parent has a pharmacist for a daughter, right? But think about what would have happened in different circumstances. Very serious issues. Another reason for polypharmacy occurring are patient factors. Patients look to be prescribed more often. Women see physicians more often, so they're gonna, want or try to find solution to some of their illnesses. And typically, poor communication can occur between the patient and the physician or any other health practitioner about their health. They may not bring things up, like, for example, financial considerations or issues with transportation. These are all patient factors that lead to polypharmacy because the physician may think, oh, well, that's not working, let me add something else. Okay, so that may be part of the problem. Okay, so this is a funner fact slide, just to take a break. How many countries around the world do you think advertise prescription drugs?
USA.
Don't say, because I know you've heard it. How many countries around the world do you think advertise prescription drugs?
Well, they promote them. Do they advertise them? Is that the key word, advertise?
Yes, advertise on TV,
Okay.
like ads or marketing, like on billboards and, huh? Can you think of one?
Besides us?
Us, United States, right? Okay, there are only 2 countries in the whole world that advertise drugs, and one of them is the United States. What's the other one? Anybody?
Canada?
Huh?
France?
England? Canada? New Zealand. New Zealand. Now, someone asked me why New Zealand, but I'm sure my answer then was I don't know, but then I looked into it, and the rationale is the same as the United States. Money. Yeah. The pharmaceutical companies want to increase their sales. Okay, let me go back to the advertising factor, because this is also a fun thing to think about. When you go home, I want you to pay attention to your viewing. Pay attention to the channel that you're going to be on. Think about who you are, what kind of audience would be watching that particular station. And think about the relationship between what's being advertised and what you're seeing. Okay, so as an example, I'm going to give you an example of the channel ESPN. Who do you think is the main audience on ESPN?
Males age 18 to
What's that?
45. Men age 18 to 45.
Yes, men. And the age is just about right. So men who are in a certain age group and are athletes, maybe not, right? What are they advertising on that channel?
Beer.
Think about what is being advertised on that channel. Jim is laughing.
Viagra.
Viagra, yes. Yes. That's one of them. That's one of them.
Very profitable.
Yes, exactly. What other things are they advertising? Hair growth. Okay. What's another one? Products for benign prostatic hyperplasia, BPH. What's another one? A good example, athletes experience a lot of pain. So they're going to advertise medications to treat pain for arthritis, things like that. Okay, now I'm going to give you a different scenario. I go into the nursing homes a lot, and no matter what nursing home I go to,
Constipation.
Price is Right. Every nursing home I go to, Price is Right is on. And it's typically geared to an older adult population. And yes, the answer is they're going to have products for constipation. And what else? What do you think?
Diabetes?
Diabetes, yes.
Yeah, what's that?
Constipation, diabetes, heart disease, depression, all things that older adults experience, right? And so these commercials are aired, and they tell you all the benefits. They'll show some happy people on the commercials. You want to be just like them after you watch it. But then, at the very end, it gives you a warning, and the warning goes, death, death. So the warnings are not really out there because it's in little print too if you want to read it. But the goal is to try to get you to buy into the product. Now, how many of you think that's a good thing? Raise your hand if you think advertising is good. Anyone? Okay, in actuality, I've polled every session and nobody seems to agree that it is a good thing. But I do want to point out that studies do show that it increases compliance, that people are paying attention to how important it is to take their medications. It's the first thing. The second thing is that they're realizing that they need to take care of their health. So they're becoming more educated about some of their topics. So I'm just throwing it out there as information that's maybe of interest to you. Now, these are some of the clinical consequences to polypharmacy. In a person who has dementia, frailty, falls, physical function and cognitive impairment, and hospitalization are huge. Okay, and that's why we have to pay attention to what types of medications the person is on, because it causes some of these very common adverse effects that, kind of overlap with the disease of someone who is aging. I have half of these. But I have to say that if you have a patient who's taking so many of these medications, it's really hard to taper and to find that just right mix to avoid some of these complications of adverse effects. These are some of the drugs that are overprescribed. I find that of all this group, in my area, the proton pump inhibitors are very, very much overprescribed. These are the Prevacid, Prilosec, Pantoprazole, Famotidine, all of these. Yes?
So what is considered overprescribed? Like, for example, I take a proton pump inhibitor and it's an allergy something B. So some of the medications we have, it's like dual functions.
Yes.
So is that considered still being overprescribed?
Not if your physician is monitoring your condition and reevaluating it every couple months. He may, or you may consider asking for a decrease in dose if that's possible in some cases. I'll give you a good example of a polypharmacy where the medication was overprescribed. I had a patient who's a smoker, and he wanted to quit smoking altogether, And so the physician prescribed a nicotine patch. And you know, that takes a couple of weeks to work and, you know, actually get the patient off the smoking part. But the patient had stopped smoking the year before and he was still on the patch. Okay, that was completely unnecessary. He didn't have to be on it because he was no longer smoking. Why they kept him on it for a year, it was overlooked, most likely, but that's a good example of an overprescribed medication.
Clarify that though.
Yes.
Because I thought when the patch is given to people, they're not supposed to smoke.
Right.
So is there a period of time that they keep the patch on and then they don't need it anymore?
Yes, the goal is to decrease the nicotine level in the body, and so that it would be tapered off. He was already on his last tapering dose, but for some reason they continued it.
There are doctors who will keep prescribing, refilling prescriptions without seeing the patient.
Yeah, no, the purpose is to stop the patient from even needing the patch at some point. The goal is to cut off the nicotine altogether. Any other questions?
I think sometimes I feel sorry for people that I see in care environments because in as much as the diet should be modified based on the conditions the individual may or may not have, I don't see nutritionists looking at, okay, this person has indigestion. So there are certain foods that exacerbate that condition.
Right.
It doesn't matter. If you're in those environments, you're going to get that food anyways. And
Right.
then you get medication to deal with it. You know, or people sitting around and they don't have enough fluids and they don't have enough fiber in their diet and they just get, what do you call it? Laxative.
Yes.
So, I don't
Yeah.
know what,
To your point, here's what happens in polypharmacy. And this is actually how it happens in a particular nursing home I work in. So this patient is prescribed a medication for cholesterol. Okay? The patient's side effect is they start to feel muscle weakness or pain. So they're going to add Flexeril. Okay, that causes some other side effects, like maybe constipation. So they added that. What should have happened is that initial, I forget which one I picked as the cholesterol, the pink one, it should have been changed to something else because not all the statins affect people the same way. That could be an approach. The other thing is that in a patient over the age of 90, we no longer push the need for a statin product. So it's not necessary at that point because the goal of a cholesterol medication is to extend their life for another 10 years. But if you're 90 years old, is that the goal you want? Still, that's a conversation you need to have for your patient.
quick question though, because what is the cholesterol medication is that supposed to maybe reduce the risk of heart attack or stroke?
It's supposed to decrease your cardiovascular risk, yes.
Right. So, could someone have a stroke and then have more complicated?
Well, the monitoring needs to happen. You need to check the cholesterol level. I have plenty of patients that have normal cholesterol levels and they're on statins. Okay? So that has to be, a discussion between the physician. And again, every patient is different. So there might be some history there, cardiovascular history in the family. Okay? All right.
I think people in hospice, and they're on their cholesterol medicine, and I always wondered why.
Yeah.
And I thought maybe, I don't know. Do you know?
Now, we can talk about details if you'd like afterwards. Okay? All right. So here we're going to talk about some tools that clinicians use. These are all tools that clinicians use. My favorite is the Beers criteria. It is a criteria that has no relationship to alcohol. It was created by Dr. Beers, who is a geriatrician. And this publication, it looks like this. The American Geriatric Society provides this. And I think you can go on the website and order them. I'm not quite sure how many, but this is a really good publication to use. This one is a 2019, and it is normally revised every 2 years. So there's a 2023 available right now. The other tools are useful, but again, these are tools that clinicians use. I like using the stop and start criteria, which was created in Europe. I like that one as well.
Now, which of these would be appropriate for non-physician caregivers?
For non-physicians, ooh, yeah, that's hard to say.
You have successfully scared me to say, don't take too many drugs. So then the question is, well, I should be monitoring this because I want to own my health care. So the question is, how do I do that?
Okay, and that's a very good question, valuable question, because what I would recommend is to have a list of that medications, look at any things that you're experiencing, side effects, any things that are of concern to you, and set up an appointment to have a consult with a pharmacist. For people that are interested in using the pharmacist, I want to point out that pharmacists are underutilized, big time. They are by far, and I'll tell you this because I work in the long-term care, and I see, overprescribing like you wouldn't believe. I usually write letters to the physician and say, could you reevaluate this? And 90% of the time they do agree to make changes.
Okay, so I know about pharmacists in the drugstore. I know about pharmacists in the hospital. Are there pharmacists that do independent evaluations? Can I get a referral from my primary caregiver to a pharmacist for an evaluation?
Yeah, what is that? American Society of Consultant Pharmacists. You can actually look for a pharmacist to do a consult for you. It's American Geriatric Consultant Pharmacist. Now, normally all the drugstores provide the service. So who do you get your prescriptions? Giant. They should have a pharmacist there that can do a consult for you.
They're so busy. So I'd rather find somebody whose focus is understanding my needs and taking time with me.
Okay. So here's another solution to that, Mr. Jim. One of them is to call the pharmacy and ask the pharmacist when you can have a consult with them. Because there are particular times during the day, like 10 to 11 is quiet time. 1 to 2 is quiet time. You don't want to come in first thing in the morning or at lunchtime or after work. Those are the most horrendous prescription times ever. You want to find, and even during the weekend they're available. So, yeah, you can call them and set something up with your dispensing pharmacist.
The other thing that you can...
So this criteria looks like this. Okay, it's a long list of medications that are typically reviewed by clinicians, whether it be a physician or a pharmacist, and they're looking for inappropriate medications that are inappropriate in certain conditions, medications that need to be monitored closely, and those drugs that cause certain serious side effects or drug-drug interactions. Okay, now we're going to talk about a plan, something that can help with you trying to use a plan to decrease polypharmacy. The first thing that needs to happen is discussing a goal with a patient. What do they want? In this case, my patient doesn't want to get rid of any of her medications. That's what she wants. So my goal to decrease is going to be very difficult because she's resistant to that, but she's compliant with her medications. If that's what she wants, then that's fine. Again, having an open communication with the patient is very, very important. Have an honest conversation with them about their lifestyle and consider where they are. In the nursing home, you know, it's much more regulated. You have nurses there that, you know, administer the medications. But in the home setting, compliance is a big issue. You have to take into consideration what's going on with the patient, like how far is the disease progressing? Are they in an early stage, a medium stage, or advancing in disease? The age of the patient has to be taken into consideration. And then medications need to be reviewed with all these in mind. Do we need to discontinue anything? Discontinue stuff that's no longer necessary. We need to look at side effects or safer alternatives. Again, there are lots of drugs in different classes. We need to consider non-pharmacological approaches. So with a patient who has dementia, I strongly recommend using non-pharmacological approaches first. And if that does not happen, that's when we need to prescribe something to taper down their behavior, but that doesn't mean they're going to be on those medications forever. We need to gradual dose reduce. We need to also consider the multiple problems that are happening with the patient. Consider lowering doses and stop medications if you can. Any questions about this plan? Okay, now I want to add that these are some of the questions that you can pose for your patient or for your loved one or for yourself. The clinician questions are pretty straightforward, but I want to reiterate that the pharmacist is often underutilized. And pharmacists are very, very helpful in looking at side effects, looking at things that need to be avoided, drug-drug interactions, making recommendations about when it's better to take it, whether it's in the morning or the evening. You know, we're probably one of the first people to actually notice that the patient may have dementia because they may come in to pick up a prescription that they picked up yesterday, okay? Or when the patient is being counseled, they are not able to grasp the message. Besides looking at medications, also look at the expiration dates. Make sure they're taking them properly. Make sure they're storing them appropriately. And again, the very last thing I want to emphasize is communication. Very, very important. This is a scenario, an actual case. This is a true case of a 94-year-old who is on these medications. She's on 1, 2, 3, 4, 5, 6, 7, 8 medications. Any comments about that? Yes. Yeah, why is she on both? Okay, so addressing LASIK is a very good point. She's incontinent. So that's an adverse effect of LASIK. What else is happening here?
Haldol and diazepam.
Oh, yeah, uh-huh. So we have her, yeah, she's on on 2 medications that may be causing some problems, like recent falls, right? Very good catch. She's on multiple supplements, vitamin C and zinc. Okay, why not use a multivitamin? And some of the dosing is off. Aricept 5, if she had dementia for a long time, she should probably be on 10. Okay, but let's see if we maybe get rid of some of these things. Maybe her dementia may not be as bad. but her digoxin dose is too high.
Is Aricept supposed to slow down the progression of the illness? I mean, at 94 years old, I don't know how long she's had, what is the usefulness of Aricept?
Yeah, so we need to look, yes, so we need to look at what's going on, like where's the progression? Is it going, yes, very good, thank you. Okay, so again, it depends on where the patient is. Is she in a long-term care setting or is she at home? Communication is important. We need to discuss the goals of therapy and evaluate all the medications, all the adverse effects. What can we discontinue? What can we substitute and make safer? Okay, so I want to thank everyone for your participation. I hope you enjoyed this. And if anyone has any questions, I'll be here.